Doctors Penny and McGuire, you guys are not receiving any compensation for helping us with this video, and you have no business relationship with the company that manufactures this product. So why are you donating your time to help us with this video?
I don't think there's anything that's more important than offloading when you're talking about a DFU. The other part is access to these devices, and a lot of patients have trouble accessing the various types of offloading devices. And anything we can do to make some of these offloading devices more accessible is definitely worth the time.
Well, the bottom line is you can't heal a wound without proper offloading. I often tell my residents I could probably heal half the wounds in my wound clinic if we simply just offload them the proper way, and we don't have to go with expensive dressings like biologics. We can just use a normal wound dressing and they'll get better. The bottom line is the longer these people have wounds, the greater the chance these people are going to have either a skin infection and osteomyelitis, or they're going to become septic.
There are literally billions of dollars spent every year on dressings, grafts that are applied to patients, flaps that are done, surgical procedures, bone procedures, amputations, and none of them will succeed without offloading. If you take $1,000 tissue graft and apply it to a patient, you might as well throw the money out the window if it's not properly offloaded. Protecting the patient so that these grafts survive and making sure that, one, they're wearing the right device, and two, they understand the importance of offloading is essential.
So what do you see as being the common gaps, or are there common gaps in the treatment of diabetic foot ulcers?
Bottom line is I think it's the misuse of diabetic shoes. Whether you're in a wound clinic or you're a private provider, you really need to offload these people. Unfortunately, what's happening is they're using diabetic shoes. These are shoes meant for preventative purposes and not to treat an active wound. It's like counterintuitive to try to use a shoe that potentially might have caused the problem in the first place. So I think we need to sit down, pick a product such as the Force, for example, and put that in the protocol for offload bearing. If we can do that, it would give the prognosis for these people to get better quicker and more cost effectively.
So I think the gaps in the system are the clinician who either doesn't listen to the research, doesn't teach themselves the offloading techniques, and is not aware of what's available to patients. The other one is the patient who doesn't believe that the offloading is important and hasn't grasped the importance of daily inspections and protection. I think that might be, a fair criticism of the system right now, is that we're not using effective offloading devices to get these wounds healed.